In this last presentation for the articulation series, I want to kind of drive it all home why this is important, right? The types of joints, especially synovial joints, are really going to matter because by understanding their structure, we can understand how they move. We can also determine things such as how much range of motion there will be or how many planes of motion there may be in a particular joint if we know the type of joint that it is. So we'll talk a little bit about range of motion first, and then I want to look at two specific joints of the body, two of my favorites, the glenohumeral joint, the shoulder joint, as well as the knee, because they're great examples of a general synovial joint, the structures that are found in these synovial joints, and how all of these different structures interact during movement. Now, when we look at each of these joints, and when we look at each joint in their individual lectures, we will talk about range of motion. The range of motion is the normal range at which that joint can move. And again, range of motion is determined by a number of factors. Range of motion varies greatly from one joint to another. It does vary sometimes substantially from one person to another. As you work with more and more clients, you'll get a good feel for what the normal range of motion is for the hip or the knee or the shoulder and the elbow, etc. And we will see differences from one person to another. Often, and most often, the amount of motion is bilaterally symmetrical from one person to another, from one side of one person to another. So generally, if a person is hypermobile in their right shoulder, they'll be hypermobile in their left shoulder. Now, this is not always the case, especially in the case of injury, or if the person performs or works in an environment where they utilize one joint differently than the other. A great example for me as an athletic trainer are baseball pitchers. While they have a similar total amount of rotational range of motion, we often see in their dominant side an increase in external rotation and a decrease in internal rotation. But again, generally we will see a similar range of motion bilaterally for most people. Even if they differ from the norm, you'll often see the left and the right are similar. We measure range of motion with a device called a goniometer. Again, you can get a quick and dirty, just kind of eyeball their motion. But if we really want to measure their range of motion, we use a device called the goniometer. Often we do that if our goal is to intervene in some way to increase their range of motion. It's great to take a concrete measurement because that does allow us to then look at the change over time. There is a pretty cool, or a number of apps that are pretty good at measuring range of motion as well, and they can be fairly accurate. And one that I use is it's made by Dartfish, and Dartfish, it allows you to take a video of a person moving and then actually stop the video and then basically draw a line down maybe their humerus and then a line down the center of their thorax and take a quick measurement of their range of motion at their shoulder. So there's some pretty cool apps for measuring range of motion as well. There are a number of factors that affect range of motion and potentially affect joint stability. One is the bony structure. The bony surfaces are going to determine what motions are allowed and often what motions are allowed. In the case of the elbow limits extension. When we get to full extension, the elbow will actually, the bones of the elbow lock together and prevent more extension. So often the articular surfaces are going to limit range of motion. Certainly the ligaments and tendons and joint capsule can limit range of motion as well. That's partly their job. If you try to hyperextend your knee, you'll note that the back of your knee gets tight. That's your joint capsule and some of the posterior ligaments of your knee getting tight and preventing excessive extension. And then muscles, because they cross the joints, can also limit motion. So if you're trying to limit hyperextension of your knee, you can also contract your hamstrings to prevent excessive extension. So again, range of motion is affected by all of these different factors. And if our goal is to increase range of motion, we may have to address tightness of ligaments, the action of muscles, etc. There is an average or normal range of motion at joints, like I said, and again, you can there's charts in your textbook as well as online that might be good to have on hand if you're trying to see if someone has normal or excessive range of motion or limited range of motion. People that have excessive range of motion at a joint or multiple joints are considered to be hypermobile, and people that have decreased range of motion at a joint are called hypomobile. And again, often we have to figure out, is this hypermobility due to some pathological reason, like maybe a history of ankle sprains, that's why they have extra motion in their ankle, or are they hypomobile because, again, of a history of some type of pathology? Again, a person who comes out of a cast, for instance, is going to be hypomobile at the joints that were in the cast because they haven't used them. So we need to restore that normal range of motion and normal functioning. So let's take a look at a couple examples of some joints. And again, we'll see some of these same types of structures that we find in all synovial joints. So this joint here is the glenohumeral joint. The glenohumeral joint is the joint between the humerus, okay, which is this bone, so that's the head of the humerus, and then the scapula, which is here. It's a ball and socket joint, so it is a triaxial, right? Triaxial ball and socket joint, synovial joint. So it has all of the features of a synovial joint. It has a joint space, okay, space between the bones that's filled with filled with synovial fluid. We have bones that are covered with articular cartilage. We have a joint capsule that we can see the edges of here that form this, again, this space where the synovial fluid is. The shoulder is the most freely movable joint in the body, and it does have this large range of motion because, one, of the bony anatomy. The bony anatomy, the socket is very shallow, so the humerus can move a large amount in this socket. We also have a very loose joint capsule. You can actually see it kind of loose here at the bottom, but the joint capsule is loose on all sides, therefore it allows for a large range of motion. But it also creates a joint that can be fairly unstable. There are some ligaments and tendons that support this joint, and I would say the glenohumeral joint, more than any other joint in the body, is stabilized by tendons. Okay? The rotator cuff muscles, we're going to see when we get to the shoulder, is the primary thing that's holding the humerus to the scapula. And especially in an active, athlete, really, it's the rotator cuff that keeps the humerus from flying off the scapula when we do things like throwing and etc. There are also a number of bursa in the shoulder. We can see one superiorly here on the shoulder, okay, underneath the acromion. That's called the subacromion bursa. And there's others found in this region as well. So again, the shoulder is an example of a triaxial joint. It's a ball and socket joint with a very large range of motion. And we have to rely on the ligaments and the tendons to hold this joint together because the bony anatomy is fairly weak. The one last structure that the glenohumeral joint has that's of interest is we have this cartilage that helps to make the socket deeper. So this is actually a cross-section over here of the glenoid labrum, which helps to make the socket a little bit deeper and add to the stability of the joint. We can see all of these structures labeled here. I just put this slide in because you can't see them in the previous slide, the labels. So you can see all of those different structures. I'm not going to test you on this now. This is something we'll cover when we get to the shoulder joint. The knee joint is another synovial joint we'll spend a good bit of time looking at this semester. Kind of a different joint because it has two joints kind of within one. We have the joint between the tibia and the femur, which is the primary knee joint. And then we also have the patellofemoral joint, which is the joint between the patella and the femur, because the patella is a sesamoid bone inside the quadriceps tendon, and obviously articulates with the femur as well. But they share a joint capsule, so if one of them is irritated and gets swollen, the whole joint will swell up. The patellofemoral joint is actually a gliding synovial joint, and then the tibiofemoral joint is a hinge joint, but it does have kind of some characteristics that make it kind of a modified hinge joint because it does have a bit of rotation in addition to having flexion and extension. But we'll spend a good bit of time looking at this joint when we cover the knee complex. The joint capsule actually is the largest or most extensive joint capsule in the body, and actually kind of interesting in that it extends all the way up above the joint as well. This is actually still part of or contiguous with the rest of the joint capsule. So it is by far the largest joint capsule in the body. And again, if a person injures their joint, even if it's down in this region, they'll get swelling that goes up even above the patella into this space, the suprapatellar bursa, because it's all connected. And again, will lead to a very large, very inflamed looking joint. If you've ever seen somebody with a severe knee joint injury, you'll see that swelling even up above the patella. But the joint capsule obviously is very large and extensive and can produce a very large amount of synovial fluid and result in a large amount of swelling. But again, a very interesting joint, one that is under a lot of stress in athletics, therefore it's injured fairly frequently, whether it be the menisci, the cruciate ligaments, or the other ligaments that support this joint. This is just, again, a picture of the knee joint with the labels so you can see some of the different structures. Again, what makes the knee joint kind of unique is, one, the bones are so large and massive. It does support a large amount of weight, but we do have fairly significant cartilage structures called the menisci in this joint. And we also have some ligaments, like the cruciate ligament, anterior cruciate ligament, that is inside of the joint. It actually is intracapsular. Most ligaments are either part of the joint capsule or extracapsular, meaning they're outside the joint capsule. We can see a couple other pictures of the knee joint. Again, in this picture, we can certainly see the menisci, both the medial and the lateral meniscus cartilage structures that help to increase the congruency of the joint, but also absorb a large amount of shock. And then we can also see the very extensive ligaments that are found in the knee, as well as the thickenings of the joint capsule that help to hold the patella in place. Now, our joints, obviously, we talked about the structure of our joints. We've talked a bit about range of motion and how these joints move, and then the different types of synovial joints. But one kind of caveat that I want to put out there is our joints and their longevity. Arthritis is inflammation of the joint. So arthritis can be something that is acute or chronic. We typically think of arthritis as osteoarthritis, the type of arthritis that individuals get from years of joint wear. I think our goal when prescribing exercise, even if we're prescribing exercise for a 20-year-old athlete, it should be aimed at helping to prevent osteoarthritis, or at least not cause osteoarthritis. So we do need to take some care in what we prescribe and how our athletes participate. Now, participation in athletics does not mean that we're going to have an early onset of osteoarthritis, but the injuries that are associated with some types of athletic sports can predispose a person to osteoarthritis. So again, when we're prescribing exercise or when we're prescribing rest from exercise or certain types of exercise, we need to keep this in mind. Certain types of exercises can actually predispose a person to osteoarthritis. Again, knee extensions with large amounts of weight in an open kinetic chain can potentially put a person at greater risk for osteoarthritis of the knee, for instance. It's better to do some closed kinetic chain exercises with body weight or slightly elevated weights just above body weight. But again, osteoarthritis typically occurs because at first the articular cartilage becomes damaged, it softens and degenerates, and eventually starts to thin and eventually be worn away. The cartilage will actually start to flake off and can lead to the sensation of grinding or the sound that's called crepitus. It's kind of, again, the kind of a creaking sound or a grinding sound when the joint moves. And eventually bone spurs can develop on exposed bone surfaces that will cause pain. Cartilage itself does not have much or any real pain receptors, but once the cartilage is worn away, people that have osteoarthritis will feel pain because it's the bone that's being irritated. Another type of arthritis that our clients or patients may develop is rheumatoid arthritis. This is different than osteoarthritis. Osteoarthritis is more of a mechanical disease. Wear and tear causes a wearing down of the cartilage. Rheumatoid arthritis is where the person's own body will attack the joint and the cartilage, and again, leading to, pain in the joint and a degenerative changing in the joint. Arthritis often can lead to the need, the pain associated with arthritis can lead to the need for a joint replacement. When we look at the hip, when we look at the knee, we will talk a little bit about knee and hip replacements, which are very common in the elderly nowadays. And again, if you work with a variety of ages, if you work with the elderly, you're very likely to encourage or work with a patient or client that has had a knee or a hip replacement. Amazing what they can do, but they do still have some limitations, and will potentially be able to do a lot of activities, but may need to be limited in some types of activities. So in conclusion, we've over these two presentations, we've examined the different types of joints found in the body. We very quickly went over the non-movable, semi-movable joints, and then we spent a little bit more time going over the freely movable joints, which include obviously are the synovial joints or diarthrodial joints. We examined the typical type of synovial joint and the things that are found in synovial joints. Again, a joint space, a joint capsule, synovial membrane as the inner part of the joint capsule, the fibrous outer portion that gives strength, and we talked about, again, the presence of articular cartilage covering the bones, and then potentially some additional things like menisci or pieces of cartilage in the joint between the bones. We talked about ligaments, muscles, tendons, etc., all potentially adding to the support and stability of synovial joints. And then we did discuss the different types of synovial joints found in the body, the 6 different types, and again, how some move in one plane, 2 planes, or 3 planes, and again are said to have 1 or 2 or 3 degrees of freedom.